So I'm gonna try to tell 3 stories. The first is about plasticity, which is the end stage of prostate cancer, at least as how I conceive of it. It's a response to treatment. And then I'll begin, and I'll have 2 other shorter stories on prostate cancer initiation, which is something that I think is equally important to study. And I want to just frame prostate cancer for you. Okay, so this is the map of the Onca print of primary prostate cancer. And the only thing I want you to take away is that roughly half of prostate cancers in US or European men are caused by a translocation involving ERG or cousins, ETS family member cousins. And they are mutually exclusive with pretty much everything else except P10. And that's relevant for the last vignette I'm going to tell you. To set the stage for the plasticity concept, this is a plot from a large consortium that Arul Chennaiyan and I led some years ago to sequence metastatic prostate cancer at scale, sort of to go with the TCGA, which was all primary prostate cancer. And there's a ton of information in here, but I want you to see 2 or 3 things. First is that 50% of metastatic prostate cancers have one of these 3, and often all 3 of these alterations: loss of P53, loss of P10, and amplification or mutation in the androgen receptor, which is, in this case, almost never seen in primary cancer, as you can see here, because it's sort of next to the 0. And that's because this is clearly a response to treatment with hormone therapy. The other one I want to point out is loss of the retinoblastoma gene, which is seen in about 30% of late stage and pretty unusual in primary.